Okay, welcome everybody to the Module 10 lecture on biostatistics. So this is where we start to get into the weeds, the unfriendly portion of the course where we learn about some of the biostatistical computations and methodology underlying the studies that we're looking at. For this lecture today, we're going to be figuring out how do we select a statistical test based on the data we have. Then we'll be looking at how do we actually interpret those tests. And then finally, we're going to be looking at different regression types and how to figure out between them and what they mean. So think about this as we go through this lecture. You are in charge of a study that you just completed. It was an RCT comparing lisinopril to placebo for congestive heart failure patients. However, in your methods, you forgot to specify which test you're going to use to compare the results. Bum, bum, bum. And your results show that the mortality rate in the lisinopril group was 3%, but it was at 4% in the placebo group. Is that a good thing? It's a relative risk of 0.75. Is your lisinopril helping? Is it not helping at all? Should we keep the patients on it? So really, what we're trying to figure out here in this lecture is what statistical tests should you use to determine if the difference is statistically significant and not just due to chance. To choose the right statistical test, it all comes down to your groups. You got to pick the right group. And so based on your research question and your design, specifically their variable characteristics and how independent they are, this will lead you to choosing the right statistical test that will give you the answer you're looking for. Now, we've seen this process of hypothesis testing several times in this class, but here it is as a reminder to show you now where the statistical test comes in. It's after you state the hypothesis and formulate it, preset your criteria, and then you're collecting data, and then you're applying some sort of statistical test that helps you to interpret and make a decision. So this is where the application of statistical tests come in the process of hypothesis testing. Now, I know you're saying, that's all well and good. I know where a statistical test is supposed to go. How the heck do I pick the right test? Because as you're about to see, there's many different tests. And so really it's three factors. You're going to figure out, are the samples independent? Okay, are they from different individuals, or are they paired? Are they from the same individual? How many groups are there that you're comparing? And then what's the variable type? So we learned about variable types in the previous lecture. So this is where it comes in, and it's key and it's really important. So these three factors will help you figure out which statistical test to choose. The purpose of a statistical test is basically to analyze the difference between two groups for an outcome and see if they're actually different by chance or if you can actually truly say they're different. And it can be more than two groups as well. So it assesses the compatibility of the results with the null hypothesis that you set for the study. An example here might be mortality in the lisinopril group versus mortality in the placebo group is equal to 1.0 for a null hypothesis. So this calls back to the little example we gave earlier. So this hypothesis assumes no difference in the mortality between the groups. And so then you have to generate a test statistic, which is basically doing a statistical test to give you a p-value, which is then compared to the alpha value that you set prior to starting the study, which is usually always 0.05. And the specific test statistics, that's a tough one, vary by test. They can be t-scores from t-tests or f-scores from ANOVA tests, etc., and we will see them. But really, all of them produce a p-value, which is what you are concerned about. So what does it do? It basically looks at your test statistic based against the null hypothesis distribution. We saw some distributions last class, and so now you're figuring out where your p-value lies on this curve here on the left in terms of the data you're inputting into it. And so if your p-value falls really far in one of the tails, like it's showing here, then you probably have a statistically significant result because it's very unlikely that your true value falls and all the rest of the null hypothesis distribution. It's so far out that we can say with a high degree of confidence that your result is statistically significant, meaning that it's the true value and it's much different than the null. Now, the null hypothesis for categorical data, because categorical data is established with a ratio, a numerator and denominator, like we learned about in the beginning of the course. So 1.0. So it'd be like those relative risks, those odd ratios. 1.0 means no difference, versus continuous data would be no difference between a group, or two groups, or three groups would be 0. There's 0 difference between them. So 0, and the center distribution centers on the mean of 0. So for that curve, you can see there at the left, if it was categorical data, the true value under the null hypothesis would see with a center of 1, and continuous would be a center of 0. And we're looking to see if your test statistic is actually falling way outside of that and basically falls beyond that 95 statistical significance threshold. Let's take a look at a test statistic calculation example. And no, you don't need to memorize these formulas or even do them, but they're here for your own information. So if you had a study design where you're looking at it and you're trying to figure out which test statistic to implement, then this one, the study design, is independent groups. So they're from different patients, okay? It's not a paired or a crossover study. They have two groups. There's a medication and a placebo group. And then they're looking at an outcome of blood pressure, which is a continuous variable that is normally distributed. So based on those factors, you have to select a test, and the most appropriate test here is a 2-sample t-test, or student t-test is what they call them. And that's the most appropriate test for independent groups, two groups, and a continuous variable. Then you have to do a test calculation. The numerator is the difference between the means versus the null hypothesis is a difference of 0. And so you do the calculation there and you'd get a t-statistic, which helps you derive the p-value of negative 3.78. The p-value is less than 0.01, which is less than 0.05, right? So we can say it is statistically significant. And so in this example, the investigator can say that the blood pressure medication they gave works better than placebo in lowering blood pressure, because the really small p-value suggests that the observed difference in blood pressure between the groups is unlikely to have occurred by chance alone. I keep talking about one of the criteria for picking a statistical test being whether it's independent or dependent observations. So here's in more detail what that means. Independent observations are observations between two groups, like a treatment and a placebo group, and they're disconnected. Okay, there is no overlap in those groups. Those are distinct groups with distinct individuals. And so again, you could compare a new drug versus standard therapy with two groups. Each data point represents a different individual. There's no relationship. In contrast, dependent observations, there's a relationship. This could be, again, crossover testing, where the patient serves as their own control, or follow-up data points for group 2 depend on baseline data points from group 1. Okay, so again, there's some sort of relationship between the individuals and their measurements. There's multiple measures in the same individual. So, for example, testing drug lit knowledge for this class before and after the semester on the same students. They're the same students having repeated measures is another way to talk about it. Repeated measures means dependent observations. So each individual is providing multiple measurements. So this has to be handled differently with different statistical tests. So it's crucial to figure out which one's which and what you are looking at in order to pick the right test. That second factor that we have to look at and to determine which test to use is how many groups are there. In most studies, there's two groups, right? There's an intervention group and a placebo group. However, in other studies, there might be 3 groups, 4 groups. There could be a lot of groups. The more groups you have, the less power you have. So you have to be careful how many groups you have. But we usually use something called an ANOVA, an analysis of variance. And basically, this is like an omnibus test, which is a fancy word for it tests to see if there's any difference between any group. But it doesn't tell you which groups have the difference. So then you have to follow that up if you have a significant ANOVA test with post hoc testing to tell you which groups are actually significantly different. So it helps you reduce the amount of statistical testing you're doing, because we won't talk about it in this class, but the more statistical testing you're doing, the more likelihood that you're going to have type 1 error. So you just have to be careful, because by chance, if you do 100 tests, you're going to have 5% of them indicate a statistically significant association, even though it might not be there, just because of the raw number of tests you're doing. So that's the reason that we generally do ANOVAs to start with, followed by post hocs. And finally, the statistical test will depend on the variable type, because that dictates their distributions, which you have to use certain tests for. Because if you think about it, if you have a different distribution with different variables, you need different types of tests to assess those distributions and whether your finding falls outside of the main bulk of the distribution. So nominal variables, like we've learned about, have no inherent order and they're categorical. So usually like a 1 and a 2, yes or no. Binary type variables generally, but they can be more than binary. And they're typically analyzed using chi-square or Fisher exact test, depending on the number of data points you have. Ordinal variables are categorical variables again, but they have a clear order, like a pain scale from 1 to 10, because it gets more intense as you go to 10, or a Likert scale. That's something like you do these all the time with student evaluation of teaching from a 1 to 5. How much did you like this course? Not very much, a little bit, very much, etc. And then continuous variables, and those ones, I should say, ordinal variables, use non-parametric tests because they're not uniformly distributed, like Wilcoxon rank sum tests. Continuous variables are the most straightforward. The ones that we generally use are like blood pressure and weight. And they're used parametric tests, which is a fancy word for normally distributed, the bell curve, okay? Like t-tests and ANOVA. If they're not normally distributed, they're non-parametric, there are non-parametric alternatives available, or you can actually log transform this data to make it normally distributed, and then you apply a t-test or ANOVA, but depends on the literature, which way you're going to do it. I've done both even in my career. And here's a nice little recap of what we've been talking about. So the level of measurement there is in the first column, and then it goes on to tell you all the information you need to know. So this is a great thing to study from. Nominal data is discrete, and so examples are like sex or race, and the mathematical operations we can do on them. Ordinal is discrete, and that's the ordered data like pain scales. Interval data is continuous, like body temperature. Remember, it has intervals between each unit that are equal in length, and then ratio data, which is continuous like weight, and it has no bounds and can be measured very precisely. The more analytically precise your instrument, the more in detail you can get. A little more on normal versus non-normal distributions, or parametric versus non-parametric distributions. Basically, parametric or normally distributed variables are the most common we see. That's the traditional bell curve I'm showing right here. Okay, and there's many tests for continuous variables that are normally distributed. We have to make sure they have independence of observations, they're continuous data measurements, they're equal variance between the groups, and so then they have a normal distribution of data, and we can apply things like t-tests and ANOVAs. How do you actually check if your data's distributed, normally distributed or not, without having to produce a little bell curve picture? They actually have, you could do visual inspection, so you could look at your bell curve picture, or you can actually do another statistical test on it. That's pretty common. And usually in softwares nowadays, you can point and click to these. And so Shapiro-Wilk or the Kolmogorov-Smirnov test are the most commonly used. And if you find significance in those tests, that tells you have non-normal data and you have to use a different type of statistical test on it. And you can also do skewness and kurtosis values, but honestly, those are generally reported alongside these formal tests that one usually uses in programs nowadays. Non-parametric alternatives, so if your data is non-normally distributed or non-parametric, then you're going to start using ordinal tests, or you're going to data transform it like I just mentioned, log transform it, or you're going to use non-parametric equivalents to a t-test, which might be like a Mann-Whitney U. So here is an excellent table for you to know. I'm pretty sure I actually give this on the exam when I give you the questions, so you don't need to memorize it. But here it is, and this is actually good to have going forward in your career, especially if you end up doing postgraduate training too. You'd be shocked how many times you have to come back to this. So the tests are listed there in the white column, and then you can tell between 2 dependent groups, 2 independent groups, or 2 or more independent groups, the type of test you need to do depending on the variable. So for example, in 2 dependent groups using nominal data, you're going to use the McNamar test. Ordinal data is the Wilcoxon signed rank test, or continuous the paired t-test, because they're 2 dependent groups. So they're matched, they're repeated measures, they're matched values in the same subject or participant. If they're 2 independent groups, so they're values from different people. Nominals chi-square, ordinals Wilcoxon Mann-Whitney U-test, and continuous is the traditional t-test. And finally, if you have 3 or more independent groups, the nominal will be a chi-square, ordinals is Kruskal-Wallis, and continuous is ANOVA. Now, I know you've been waiting with bated breath to get to regression analysis, and here we are. So regression analysis can proceed in 3 basic forms. There's a lot of them, but this is what we're going to learn about here. Simple linear regression, okay? So it looks at the relationship between an independent variable and a continuous outcome. And it makes a best fit line and gives you a p-value. It'll actually give you mostly the same result as a t-test for all intents and purposes, but it's usually 2 continuous variables together. Multiple regression, it gives you the ability to enter multiple variables into a regression. So this is where you can account for the confounders that we talked in the first half of the course. If you know that there's an imbalance between your intervention and placebo group in sex, you can enter that into a multiple regression to quote unquote control for it or adjust your outcome and see if it's still significant. And then if you have non-normal or non-parametric data, you use a logistic regression, which basically implements the same thing as a multiple regression, but for non-normal data. And here it is again in words. And the other thing I'll say here is that the logistic regression is just not only non-normal data, but it's for non-continuous data. So it's for nominal outcomes. You can actually apply a regression to it. So if you wanted to look at, is death more prevalent with treatment, then that's a yes or a no for death, right? And so you can actually apply a logistic regression with multiple variables into that model. So please remember that it's not just for non-normal data. It also is for non-continuous data as well. But you can see here what a linear regression is, and the purpose of a regression analysis is to look at the relationship between 2 or more variables of interest and see if they predict your outcome. Now you're probably like, what the heck is a regression, right? So a regression is basically creating a line of best fit with the 2 variables you're interested in. So your independent and your dependent variable, your x and your y variable. And it generates this line so that it fits all the data points the best that it can. It's called the best fit line. And so it minimizes basically the distances on average across all your data points that you have, which you can see in this figure. You can see some data points fall more off the line, some less, but the line kind of goes through the middle of all the data points, okay? And what is this line used for? It can be used for essentially generating a new data point, a new independent data point on the x-axis, and predicting where it would probably fall on the y-axis, okay? And best fit lines can be really, really tight, meaning they are highly correlated to the data, or they can be more loose, maybe where they're more horizontal. So basically, there's a lot to go into on regression, which we aren't going to do into this class, but regressions become much more technical as you go deeper into them. But for this class, you need to know there's a best fit line, and then you can do predictions off of that line. And the other great thing about regressions is that you can add in 3rd, 4th, 5th variables for confounding control while still modeling the relationship between that x and y variable, the independent and dependent variable. So basically, it's much more sophisticated than just looking at a correlation between x and y, because you can add in those extra variables, meaning we can get a more precise estimate of that relationship that accounts for confounders. We went over this in a previous class, but how do you figure out which variables can be potential confounders in the main relationship you're looking at? So again, looking at lisinopril and placebo and its effect on blood pressure, how do we identify those confounders? We do that table 1 demographic comparison, clinical comparison between the two groups of lisinopril and placebo. And what you can see here is you always look to see which variables are significantly different. So we don't really, obviously the outcome blood pressure isn't a variable we would control for because that's the variable of interest, but either age, gender, and previous stroke would be the big ones where you're looking at the differences to see if they are potential confounders, okay? And so the other thing that I'll say in this table is that the outcome of blood pressure is actually the endpoint blood pressure between lisinopril and placebo. It should say baseline blood pressure is the first blood pressure listed on the second line there. So baseline differences actually could account for the outcome differences. And you can see here, when you look at the right and the p-value, age and blood pressure were significantly different between the groups. So these certainly need to be controlled for because they could influence the outcome between the groups of endpoint blood pressure. And so we need to figure out, are they actually skewing the results we're seeing here? Are they masking some effect? Are they actually the things that are causing the blood pressure differences? So that's where linear regression comes in. We can add those into a model. And then if we still have endpoint blood pressure differences, then we can say pretty confidently, no, age and baseline blood pressure actually aren't skewing the results. One good skill to have is to be able to interpret a regression output. And so I don't think you need to be experts on this for this class, but it's good to know when you do a statistical test in any sort of software package out there. SPSS is probably the common one students use to see what it actually looks like. So here is one for a logistic regression. So remembering a logistic regression is mainly looking at nominal outcomes, so yes or no, and seeing what the effects are here. So this logistic regression specifically looked at whether using multiple renal function equations or time spent in practice increases the likelihood of deviating from FDA dosing guidelines. So the independent variables are how many equations you use, how much time you spend in practice. So how many equations you use, 0 versus 1, that would be the nominal variable, which makes this a logistic regression. Time in practice is a continuous variable, so that could have been a linear regression if it didn't have the nominal in it. So whenever you have a nominal variable, you're going to do a logistic regression. That's just what happens. You can't go the other way. And then the dependent variable is the likelihood of deviating from FDA dosing guidelines, probably by some sort of survey measure. And so what do we see here in the output above? So the little table shows you the variables in the equation. So again, the nominal group variable, 1 equals multiple variables, 0 equals single variable, time spent in practice. You have the beta coefficients. So minus 0.755 for how many equations you use indicates that being in this group decreases the log odds of deviating from guidelines. So basically, the more equations you use, the less likely you are to deviate from FDA dosing guidelines. In contrast, for time in practice, we have a positive coefficient, beta coefficient value of 0.118, which indicates that the more time you have in practice, the more likely you are to deviate from FDA dosing guidelines. And beta coefficients tell you kind of the magnitude of effect, but you need to know whether it's statistically significant. So you keep moving to the right in that table until you get to the SIG column, SIG, and then you can see the p-value for each of the variables we entered into this logistic regression. And so we can see that if you use multiple equations, it's statistically significant. So it actually has a significant effect on whether you adhere to FDA dosing guidelines, versus time in practice was not statistically significant. So here's just a simple output of a regression where you can look at each variable you enter in, see the magnitude of effect and its direction based on the beta coefficient, and then scan over to the significance value to know if that variable actually has a significant effect while holding the other variables constant on the dependent value. So think about that for a little bit. Listen to this slide again and make sure you kind of understand what's happening when you enter in multiple variables into a regression analysis. The reason it's important to always look at the beta coefficients is because you want to always go beyond p-values. P-values are good because they tell you whether something is statistically significant, meaning that it's not likely due to chance, right? But we need to know, even if something's statistically significant, maybe it's not clinically significant. Maybe the magnitude effect is so tiny that it's still not worth treating patients and potentially, exposing them to unwanted side effects. So you always do the statistical analysis, figure out statistical significance, and then you have to look at more of the magnitude effect with something like a beta coefficient and its direction to give clinical significance, and whether you need to use your clinical judgment on whether or not that is worth, based on your risk-benefit calculation, of treating those patients with whatever drug was being evaluated in that regression analysis. To reiterate, statistical significance is different than clinical significance because statistical significance is helping us rule out random error or chance because we compare our significance testing to our pre or a priori specified alpha value, which is usually always 0.05. And so it helps us to assess the impact of bias and confounding when looking at the results in an objective, unbiased manner, versus clinical significance, right, is going to have more biases and subjective assessments with them. And here we see clinical significance. So clinical significance is subject to your professional judgment. You take the statistically significant result and then you say, well, how big was the effect? What was the magnitude effect? What was the direction? What was the effect size? What are the potential harms and benefits of the drug as a whole? What alternative treatments are there? Are there costs, patient, system-wide, of using this drug in the context of how good it is? And what are the patient preferences for the drug? So basically, statistical significance is certainly necessary, but it's not sufficient to determine whether a patient needs a drug or should be treated with a given drug. To wrap up this lecture, we've kind of figured out what tests do you use depending on the variable in question, the specific situations, all those things we thought about, the independency of the variables, how you're looking at them maybe over time, are they matched pairs, things like that. All those things that go into test selection. And then how do we actually interpret them in terms of statistical and clinical significance? And then how do we look at different types of regression analyses? How do we understand what a regression analysis is when you put in multiple variables? And these types of things will help you in your studying for the tests. So you have to make sure you understand the statistical tests. What does a statistically significant value mean? And then how do we actually try to use that statistical significance to determine clinical significance?